Dietitian. Thanks for inviting me to speak today, and thank you all for staying here so late in the day on a Friday. I'm going to be talking about some topics related to nutrition and SLOS. I'll start by listing some of the nutrition-related issues that are commonly seen in SLOS. Then I'll go through some of the major components of nutrition that I consider when doing an evaluation, and how to help people with SLOS to meet those nutrition needs. And finally, I'm going to talk about some options that are available for kids who are tube-fed. So some of the nutrition-related issues in Smith-Lemli-Opitz syndrome are poor growth compared to the general population, feeding problems that can start at the very beginning, hyperreactivity to sensory input, which can lead to oral defensiveness and significant eating selectivity, and intestinal dysmotility that can worsen reflux and constipation. And these are all issues that can affect feeding and growth, and in many cases necessitates the need for a tube feeding placement. So when I'm doing a nutrition evaluation, these are the major components that I'm looking at: the calories, the calorie intake, growth, protein, fluid, fiber, vitamin and mineral intake, and in SLOS, the cholesterol intake. So often it's difficult to use standard predictive equations to estimate the calorie needs in children with SLOS. And so often the best way to determine if somebody is getting enough calories or the right amount of calories is to track the growth compared to the growth curve over time. So ideally, children who are growing will track in terms of their height, their weight, and their body mass index. They'll track parallel to the growth curve. Now, since children with SLO do have altered growth patterns, Dr. Denny Porter at the National Institutes of Health and his team developed some SLOS-specific growth curves. And I know that Dr. Williams, I believe, touched on this yesterday. I'm just going to review it briefly again. So just to orient you, this is a growth chart for the body mass index, or the BMI, which is basically the ratio of a child's weight to their height. So if a child has a low BMI, that can indicate that they might be underweight for their height. Is this the pointer? So along the x-axis here is the age, and up along this, going up the chart is the body mass index. And the dotted lines represent the CDC growth chart, which is for the general population. And the solid lines represent the SLO growth chart. So you can see that there is some overlap here. So a body mass index for a child with SLO can overlap with the general population curve. But then you also have this area down here where a child with SLO might have a body mass index that's lower than the general population curve, but it's still perfectly fine and typical for someone with SLO. So these charts are really important to consider because it can avoid a scenario where a practitioner is over-prescribing calories and overfeeding these children in order to get them on the regular growth chart, because overfeeding can come with its own issues, like it can worsen reflux, and if a child is able to take in those calories and assimilate them and actually put on the weight, it can lead to excess adiposity, excess fatty tissue, which can interfere with gross motor development and the ability to mobilize. Now, there are times when a child with SLO, you want to optimize calories so that they can continue to grow along their growth chart. And I've just listed some commonly used sources of fats and oils and some of the foods that they can be added to. And it's important for everybody to get adequate fluid intake, but especially with people who are prone to constipation, you don't want dehydration to be exacerbating factor. So But we all know that you can't force anybody to drink. So for those children who are orally fed, how can we increase the likelihood that they are going to take in adequate fluid? So one way would be to keep fluid accessible to the person all day. Is calculating even if they take a tablespoon of fluid in several times an hour, over the course of several hours, that can be an additional 4 ounces, which could be significant for a small child. If a child's able to respond to goals, or they respond well to goals, you can set incremental goals, mini goals, throughout the course of the day, so that by the end of the day they've reached their goal. If a child is in school and they have an individualized education plan, you can make fluid intake part of that plan so that school is also prioritizing fluid intake. And then you can try to use food sources of fluid as well. Fruits and vegetables are very high, have a very high water content. And then one more point I just want to make about fluid intake is that unlike calories, the body can't really store fluid very well. So for kids who are being fed through a tube, and they're getting the bulk of their calories or their fluid overnight, they're probably going to urinate out the extra fluid that they're getting overnight. And then if they're not getting enough during the day, they could potentially become a little bit dry or dehydrated during the day. So it's just important to try to evenly distribute the fluid throughout the course of the day. Fiber is another factor in managing constipation. Insoluble fiber is the type of fiber that's most effective for managing constipation. So I've listed some examples here. Bran can be found in cereals or muffins. All of these foods contain insoluble fiber, but when you're talking about fruits and vegetables and beans, it's really the skin that contains the insoluble fiber. So making sure, if possible, to include that as part of the diet. And then sorbitol is a carbohydrate that's in certain fruits that can also serve as a laxative. So trying to get these sorbitol-containing fruits into the diet, either in whole form or in their dried fruit form or as juices. With regard to vitamins and minerals, some common deficiencies in children in general are calcium, iron, and vitamin D. Now, vitamin D levels tend to be very good in children with SLO. But if a child has eating selectivity and they're omitting whole food groups, these are some additional vitamin and minerals that you might need to consider getting in other forms. And then there are certain medications that can interfere with vitamin and mineral status. So the anti-reflux medications that are commonly used in SLOS can decrease the acidity or the acid level in the stomach, and a low acid level in the stomach can decrease the efficiency by which iron and calcium are absorbed. And so even if a child or anyone is getting enough calcium and iron in the diet, they may not be absorbing all of that. And so it's important to just keep that in mind. With regard to iron, you could get an iron panel blood test. And if supplementation is indicated, you could talk to your provider about trying every other day supplementation as opposed to every day, because some recent evidence has shown that that every other day supplementation can be almost as effective as daily, but maybe decrease some of the GI symptoms that they experience as a result of iron supplementation. With calcium, you can't measure calcium status by a blood level because it's very tightly regulated. So you just want to make sure that your child is getting enough calcium, the amount that is recommended for their age, and maybe a little bit more. And if supplementation is indicated, you can use calcium citrate as a source of supplement because that form does not require as much acid to be absorbed. Certain anti-seizure medications can also decrease the status of certain vitamins and minerals, so it's just important to talk to your provider about monitoring those. And then just some general comments about vitamin and mineral supplementation. They're considered to be dietary supplements, and dietary supplements are not well regulated by the Food and Drug Administration prior to hitting the market. So there's always a risk of a dietary supplement having contamination with other things, or having a content that is different than what's listed on the label. So I don't know really how to get around that, except sometimes I'll recommend, if possible, to go with better known companies, just because if their reputation is at stake, they may have more motivation to put out a high quality product. The liquid formulations and gummy formulations of multivitamins tend to be less complete than the tablet forms. And few multivitamin mineral supplements, even those labeled as complete, actually contain everything that your child needs, specifically the calcium, phosphorus, or magnesium needs. And you usually want to avoid megadoses of vitamin mineral supplementation unless otherwise indicated. So I think you've heard a lot about cholesterol supplementation if you didn't already know. Egg yolk is the biggest, most common source of cholesterol in the diet, and we have different forms. And if you're not familiar with the Oregon Health Sciences University Bionutrition SLO cookbook, it can be found on the SLO Foundation website, and it's a really great resource for incorporating more eggs into the diet. There's also various forms of cholesterol suspension. And then these are some of the medical foods and dietary supplements that I'm aware of. And I don't endorse any one of these products over another. And if a product that you're familiar with is missing, that was an unintentional omission. But Colimax is a powder that can be mixed with foods or thick liquids. And Colextra is a powder that can be mixed with formula and administered through a feeding tube. So I don't have a lot of experience in using that, and I'd be curious if anyone is using the Colimax tube feeding through a tube. Yes, but specifically the tube feeding. And it works well? Great. Okay. Uh-huh. Oh, that's good to know. Okay, great. And then there's a diet. Oh, I'm sorry. Yes. So she was just saying that you can repeat your own question.
Okay. I'm not used to having to have one of these because I have quite a big mouth, but we do use the tube feed version, and we had used the other, and we mixed it with applesauce, and we got very creative. We would put it in a baggie, put the applesauce and the powder in there, and knead it, and then cut the corner off of the bag and shoot it into the syringe so that it would work good. And then, but the tube feed one is great. It does dissolve. It's not real fast. So you don't want to think you're going to do it real quick. It doesn't dissolve as quick as some other things, but it does mix really well. Okay. We just shake it up and give it.
That's really good to know.
Yeah.
And then there's a dietary supplement called Sonic Cholesterol, which is a crystalline powder cholesterol that's in a capsule. Okay, so taking all of these nutrition components together, this is what a well-balanced, varied, healthy diet looks like for 1,200 calories a day. And I realize, many of you are looking at this thinking 3.5 cups or 2.5 cups of fruits and vegetables. There's no way that my child is going to eat that, but just because of the significant selective eating that a lot of kids tend to experience. So, what are some ways that you can try to improve the dietary balance and variety, or just diet quality of your child's diet? And this is for kids who eat orally. So I like to think of it sort of a two-pronged approach. So on one arm, I think about what we can do today that is going to have long-term effects down the line. So you're not going to see results right away, but things that you do now may have an effect, in 3-5 years down the line. And I think one of the most important things is just exposing your child to a variety of fruits and vegetables repeatedly in whatever form they tolerate. So that could be just putting that fruit or vegetable on their plate and just letting it sit there. If your child gags seeing that green vegetable on their plate, then try putting it in a serving bowl in the middle of the table, or have them see it on your plate and you eating it, or have them, watch you prepare foods. Whatever way that you can get them to have more exposure to, not just the tasting it, but just seeing it, seeing the different colors, smelling it, just being around it. Because down the line, exposure is probably one of the best way, or, without exposure, they're probably not going to incorporate it into the diet. But these kids aren't just picky eaters where they prefer French fries over broccoli. These are significant sensory issues in many cases. And so there can be a lot of anxiety around being exposed to food. And so you want to avoid any kind of unpleasant meal times or battles over eating. It's just a matter of exposing it in a low stress, pleasant way. And then you can consider feeding therapy, which I'm going to talk a little bit more in a minute. But in the short term, you want to know how can you get these nutrients into your child. And we talked a bit about vitamin and mineral supplementation already. But I think just trying to figure out the most palatable form of food for your child, and it's going to depend on what they tend to be most sensitive to. So some kids really are turned off by green colors of vegetables, and others don't mind the color. So just some kids prefer soft textures because they're easier to chew, and some are really turned off by the mushy texture. So it's just a matter of working with knowing your child and what they tend to be more accepting of, and trying different textures, pureeing fruits and vegetables, and finally dicing them, adding them to various foods. Some kids like really strong flavors, so maybe trying to incorporate balsamic vinegar or lemon onto the food to see if that helps to make it more palatable for them. And some kids like to dip their foods in things, so maybe hummus and guacamole would be really healthy dips, but even if it's ranch dressing, maybe have them use a carrot to dip into that ranch dressing, and even if they're not eating the carrot, it's just another way to expose them to those foods. And it's tricky because you don't want to feel like you're tricking your child or hiding something from them. You don't want to do anything that's going to betray a trust that your child has in you. But I just like to think of it as maybe trying new recipes that incorporate fruits and vegetables in a way that just might be more acceptable to them. Okay, so feeding therapy. So some of the potential indications for feeding therapy, there's a lot of overlap between these and what we see in SLOS. So limited or poor oral intake, sensory problems, chewing difficulties, history of gagging, lack of oral feeding experiences, and that might be a child who's been receiving tube feeds and is now ready to progress to oral intake. So some of the targets of therapy would be oral motor skill development, expanding the amount or the types of foods that are consumed, and creating a positive association with food. So the options are hiring or accessing a private feeding therapist, or through an early intervention program in your area. That kind of feeding therapy is usually once or twice a week. If you feel like your child needs more intensive therapy, there are feeding programs available throughout the country. Again, this is a much more intensive therapy. It's usually daily. It can be inpatient or outpatient, but it's usually daily for a period of time, and it's conducted by a multidisciplinary team where they look at every aspect, the gastroenterology, behavioral, all of that. And they not only work with the child, but they work to give caregiver training, so that you can take these successes home to your home setting. But just like with anything, it's really important to have good communication. So making sure that you're sitting down with the team and that the goals that you have for this therapy are the same goals as what they have for the therapy, and making sure they line up and that they're feasible, and understanding the methods that are going to be used in the therapy and making sure that you're okay with those. Okay, so the last part of the talk, I just want to talk more about nutrition through the feeding tube. We've used, commercial formulas for decades to nourish children through the feeding tube. But in recent years, and probably about the past 10 years, there's been a growing interest in blenderized foods through the feeding tube. So I just my goal is to just talk about the objective kind of benefits and considerations for each different modality so that you can, weigh the pros and cons for your child and your family and decide what works best for you. So, commercial formulas have been a main source of nutrition for kids for decades who require tube feeding. And they have everything, a complete formula has everything that your child needs to grow and to thrive. Some of the benefits of formula are that they provide complete nutrition. Many of them are already ready to feed, so it requires minimal preparation. They're sterile. They can be delivered either continuously using a feeding pump or as a bolus feed, which is just a larger amount of volume in a shorter amount of time, mimicking like a meal or a snack. There's low risk of clogging the tube. It's usually covered by insurance, and formulas can address special medical needs. I'm not going to go over these slides, but you'll have them if you access this talk later. So some of the benefits of blenderized tube feeds are if you're blenderizing whole foods and using plant-based foods, you're going to have more fiber and more phytochemicals in the blenderized feeds. So we already talked about fiber. Phytochemicals are compounds that are in plants that are not essential for life, but they've been associated with improved health outcomes. So there's over 5,000 different phytochemicals among different plant foods. They're what give fruits and vegetables their colors and their flavors and their odors. And their intake has been associated with decreased risk of cancer and cardiovascular disease and, in some cases, lower inflammation. So that's one way to get more of these chemicals is to use blenderized feeds. You also have a lot more flexibility in the foods that you give to your child. And there have been some recent studies that have shown that blenderized feeds can improve some of the GI symptoms that are seen in kids with SLOS. So under the umbrella of blenderized feeds, I think there are three main subcategories. So in one scenario, a child would be receiving 100% of their nutrition from blenderized feeds. In another scenario, you might rely on a formula for the bulk of their nutrition, but then supplement that with blenderized feeds. And in this third scenario, you could use commercial products that are pre-prepared blenderized feeds. Okay, so using homemade blenderized feeds as a sole source of nutrition gives you a lot of flexibility in the foods that you give to your child, and they can be lower cost than paying out of pocket for a commercial formula. Some things to consider are that it's really hard to get a calorically dense product with all of the nutrients that your child needs. So basically, it's not as calorically dense as some commercial products, which just means that you would need to give higher volume to meet all of the needs. It needs to be administered as a bolus feed and into the G tube. So your child needs to be able to tolerate that. And it's usually a very thick formulation, and it needs to be pushed through a syringe. Nutrient deficiencies are more likely. So is the risk for clogging the feeding tube, and so it's important to have a 14 French size tube or larger. You really need a good blender, which can be costly. There's a lot of food safety considerations that you need to think about in preparing, storing, and administering a blenderized feed, and it requires a lot of preparation time. So the second option is to use formula is the bulk of the nutrition and supplement with blenderized feeds. So this gives a little bit more flexibility in the schedule. You can reserve preparation time for when you have more time in the schedule. There's less concern for meeting nutrient needs from the blenderized feeds alone. You can still provide some fiber and phytochemicals. And I would recommend focusing on fruits and vegetables if you're going to use this method. And you always have that formula supply as a backup in case in situations where you're not able to prepare feeds. And then the third option would be pre-prepared commercial blenderized feeds. So these are a little bit more easy because they come pre-prepared. They're more calorically dense than homemade feeds, and many can be run continuously through a feeding pump and even into the small bowel. So some considerations with these products are that some are not nutritionally complete, so it's important to know which products are complete and which products need to be supplemented. Some of them are very high in fiber because they're plant-based, and this is great. It's just you may need to transition your child over more gradually so that you improve their tolerance of the high fiber diet. They may be very high in fat, which can slow gastric emptying and increase the risk of reflux. And then if insurance doesn't cover them, they are very expensive. So if using blenderized feeds is something that you're interested in starting, I think talking to your primary physician and your gastroenterologist is really important, just to make sure that you're kind of cleared for that next step, making sure that the GI tract, stomal tract is well healed and ready for that kind of feeding. And then working closely with a dietitian is really important, just to make sure, especially if you're using homemade blends, that you're getting all of the nutrients that you need. And the Ole Foundation is also a really good resource. So in conclusion, getting optimal nutrition can be challenging in the SLOS, but I hope some of the things that we talked about might be helpful in getting your child to the next step. And the best method for optimizing nutrition is going to differ from family to family. Everyone needs to weigh the pros and cons and decide what's right for them. So thank you.
I have a question. My daughter's been tube-fed her whole life. She's 32. At one time, we could give her some pureed baby food by mouth, and then she had oral surgery, and she wouldn't have anything by mouth. But I've noticed a lot of parents are doing blended food through the tube. We were never given that option. Is it too late to even try to introduce that to Julie?
No, it's never too late.
Okay.
No, yeah. I would, talk to your doctor and your dietitian. I don't know if you'd want to try full feeds or if you'd want to just start with supplementing the formula. That I would probably recommend starting with that and just seeing how it goes. Yeah. And again, I would recommend starting with pureed fruits and vegetables because those are going to have the most phytochemicals and fiber content. And if the formula is providing the protein and the vitamins and minerals, so just focusing on those phytochemicals and the fiber would be a good way to. I think it's great to start now.
Okay, thanks.
Yeah.
I might try it.
Thanks, Whitney.
Can you just refresh my memory with you say 14 French. I can't remember. Ellie's in an 18 French. Is that
that's bigger.
That's bigger. Okay.
Yes.
Well, because I do
sometimes
jewelry,
I know.
and the wire is smaller the bigger it goes. So
Yeah.
I was like, I couldn't remember if it was that.
That's
so,
a great
okay.
question.
Okay.
Yeah.
For the Colextra, and I know you said you didn't have very much information, so I guess maybe kind of throwing it out there to anybody that knows. We're currently taking or on the cherry solution, and how would I know how much of the Colextra to accommodate for what we're getting now? Would I talk to
I think your physician, whoever knows the concentration of the cholesterol in your suspension,
Okay.
so can help you figure out the total amount of cholesterol that you're getting from suspension. And then the website tells you how much cholesterol is in a scoop of either the Colimax or the Cholestra tube feeding.
Okay.
So, yeah.
So I
That
would
would be an
probably
easy
just-
thing to do if you're interested in doing that. You just need to, either the pharmacist or your physician could help
Okay.
you.
Would I need to take, would I need to take the nutritional information, or not nutritional information, the
Yeah,
information to my physician to get them to make that calculation, I guess? Based
Yeah,
on-
that would be helpful. If you just want to print out or write down how much cholesterol,
Yeah.
how many milligrams of cholesterol is in a scoop of each of those products, whichever one you want to use, and yeah, sit down together and do the math.
We're paying $285 a month for cholesterol supplementation, which is, half a car
Yeah.
or more, really, depending on the kind of car you drive. So, and see, I have no idea how long that would last, but I would imagine it would probably be at least a month. Just, he's 50 pounds. Yeah, so it would probably be comparable to, and I'm just curious as to if that would be an option for us.
I think, yeah, just discussing that with your physician, but yeah, it would be an easy conversion if you both decide that that's the way you want to go, and it sounds like it's much less expensive, so.
Does anybody know if they send samples out? They will? Okay. Okay. Can I just do it myself, or does my physician? Okay. Thank y'all for.
Yeah, thank you. All right, thank you.